Hello and welcome to your lecture. In this recording, we're going to be addressing the anatomy of the respiratory system. So let's walk through it. This is chapter 10 in your textbook. As we know, or I think we know, the respiratory system has an intent and purpose to do gaseous exchange. So we're truly exchanging information, if you will, with the air in our body or between them. So we understand that one of its primary roles is to supply oxygen to the body and then be able to eliminate carbon dioxide. Bigger than that though, if I haven't expressed this before, our respiratory system is our primary buffer system. This is the thing that helps us maintain an appropriate pH within our blood. If something doesn't happen adequately at this level through respiration, then our kidneys are our secondary buffer system. So we have like a backup method to help maintain the pH of the blood, which, as we've noted before, is extremely relevant and important. If pHs and or temperature get too extreme, we begin to break the body down. So when we talk about the respiratory system, we have to understand its intimate intertwining with the cardiovascular system. Now, I think we're also being demonstrated too that all systems are intimately intertwined, but these two specifically, like some other cases we've seen, cardiopulmonary system is what we call the system when we blend heart and lung. So some of the major structures of our respiratory system: the nasal cavity, the pharynx, the larynx, the trachea, the bronchus, and the lungs themselves. When we look at respiratory system, we're going to break it up into upper respiratory and lower respiratory. Also, we're going to have within the respiratory system a conducting system, which is pretty much everything until it gets down to the true respiratory division of the respiratory system, meaning that this division, that respiratory division, is the actual part that is responsible for the gaseous exchange. Everything in the conducting division is just to get the air to that part. So let's walk through some of the anatomy and some of the structures that we're going to see in the upper respiratory tract. I think we're familiar with the idea of the sinus. Please be aware that there are more sinuses than just the frontal sinus. We're used to that one, creating pain and pressure, but you do have a sphenoid sinus as well. And the purpose of sinus cavities within bones is to help warm, moisten, and purify air. You also have a mastoid sinus, which is on your occipital bone, the back part of your skull, right behind your ear. So oftentimes, if you have any inner ear congestion or infections, you're going to notice that the mastoid sinuses can become inflamed and or infected, etc. So let's look at a couple things here. On the left side of this slide, let's talk about the pharynx and its division. So you have a division of your pharynx called the nasopharynx. That's right at the back of your nose. Right at the back of your nose, you have the pharyngeal tonsil. Then you have a division going down your throat, which is the back of your throat, called the oropharynx, right behind your tongue. In that region, we have the palatine tonsil. Under the tongue, at the back portion, you have your lingual tonsil, and that makes sense why we have things there, because, as anything's coming into our mouth, it has to be able to filter either air or food. One thing I want to point out here as well, let's keep going. Inferior to the oropharynx is the laryngopharynx. The laryngopharynx is posterior to your larynx or your voice box. Okay, then as we keep going inferiorly, the portion of the respiratory system at this point below the laryngopharynx or below the larynx is your trachea. Okay, still in the conducting division of your upper respiratory tract. Posterior to that is your esophagus. Your esophagus is the tube that, moves your food into your stomach. The trachea is for air or for breathing and respiration. Now, parts of the larynx will include the epiglottis. The epiglottis is a flap that, as you swallow, has this neat little dynamic of how it works and the muscle contractions. It is a little cartilaginous flap covered in epithelial tissue that when you go through the swallowing motion, it will close over the trachea so you don't get food in your air pipe or in the trachea. Then we have something called the thyroid cartilage within the larynx. And there are multiple other cartilages that we could discuss and or talk about, but that's the primary one. We also have our vocal folds here. Now, what we know about our vocal folds is there's a false vocal cord and true vocal cord. Okay, these vocal folds also have to do with the swallowing process. I would say more so than they do with the creation of phonation. The vocal cords, again, being the fact that we have true and false ones, which we may or may not get into that information, but there are vocal folds or cords that have different jobs to do. So if we look at the nasal cavity, let's walk through the nasal cavity as well. Okay, the very first part, okay, you have your nostrils or your nares. That's the opening to your nasal cavity. The very first part on the inside of your nose is called the vestibule. Okay, this is like a little outpouching where the air comes in, starts to get warmed up and stuff. Now, within the nasal cavity, you have a right and a left divided by your nasal septum. The nasal septum has a cartilaginous part as well as a bony part. We'll have ridges or what's called a nasal conchae, superior, middle, and inferior. And they'll have these little depressions between them called meatuses. These ridges serve the purpose of, pulling the air over them, okay, so that they can get warmed, the air can get moistened, etc. Interesting fact about breathing through your nose, okay? Your nose has in these areas, okay, in the nasal fossae on one side or another, erectile tissue. This erectile tissue will have a large amount of vascular flow to it. The purpose of this is so that the mucosal lining of these cavities can be rehydrated or remoistened or replenished. So interestingly, about every hour, your nose will swell up on the inside on one side. So if you've ever noticed that you can, in this hour, you can breathe better on the right side of your nose, and in the next hour, you can breathe better on the left side of your nose, that's why. Okay, this little feature switches on and off between sides of the nose. Okay, functions of the upper respiratory tract is our passageway. And to filter and remove foreign particles, we already know that it humidifies air coming in. It does help produce sound. It does help provide a sense of smell, and it will aid in immune defense. I already talked through the nose and the nasal cavity. Let me talk a little bit more about some of these other points we can talk about. Within the vestibular region, we're going to notice cilia. Oh, also the nose hairs, okay, at the entrance or where the nostrils and nares are, they're called vibrissae. Within the nasal cavity, we do have different types of cells that have different jobs. Okay, within the nasal cavity, we do have an olfactory region that will have a lining for the purpose of smelling. So it will have olfactory receptors, and then really the rest of the cavity can be considered the respiratory cavity, again, where it's cleaning, purifying, moisturizing the air. Okay, I mentioned the concave. Those are those three ridges. The palate. Let's back up to the picture so I can show you the palate. Okay, the roof of the mouth is your palate. First part is the hard palate. Remember, we had like the palatine bone and the palatine process when we looked at the maxillary region of the cranium in the facial bone section. But the back ends are off of the back end of the hard palate is our soft palate. On this, you can palpate this with your tongue or even your hand if you want, okay? So that's the back portion of the roof of your mouth. Now, off of this then comes the uvula. Now, this is the superior division of the oropharynx, okay, which then goes down to the laryngopharynx at the epiglottis. So the uvula is that piece of flesh that hangs down in the back of your throat from the top part. Okay, sinuses, air-filled cavities, they do serve, as we mentioned, to warm and moisten the air. They do help to amplify the tone of our voice. And interestingly, they help reduce the weight of the head. If we understood that or understand that or can understand that when we're talking about the fact that, like when we look at compact bone compared to spongy bone, okay, spongy bone having the trabeculae and the way that it is created delivers an ability to have a lightweight feature to bone. Okay, the pharynx. I've mentioned all the divisions: nasopharynx, oropharynx, laryngopharynx. One thing to mention is that the eustachian tubes will drain into the back end into the nasopharynx. Okay, the tonsils and our larynx. We remember from the lymphatic section that the tonsils are lymphoid tissue. They're very relevant and very important as one of our first lines of defense against infection. The larynx itself has 8 cartilaginous plates. Okay, I mentioned the thyroid cartilage. There are other different anatomical cartilaginous structures within the larynx. The larynx or the thyroid cartilage of the larynx is your Adam's apple. Obviously, the size of the laryngeal prominence, okay, is dictated by the presence of testosterone, presence and amount of testosterone. So then we have the epiglottis. The epiglottis is a little spade-shaped piece of cartilage, again, wrapped in epithelial tissue that will close over the trachea when you swallow. And again, part of the larynx are vocal cords, the vocal folds, and the glottis. So if we have an epiglottis, we're going to have a glottis. Okay, so within the lower respiratory tract, this will include the trachea, the bronchia, and the bronchioles, and the lungs. So let's walk through the name of some of this and how it goes. So here's our larynx, okay, and the thyroid cartilage and the laryngeal prominence is the like kind of like the pointy part of the cartilage in your Adam's apple. Then the trachea. The trachea, your windpipe, is about 4 inches long and extends from the end of the larynx, which is about the 5th thoracic vertebra. Or, I'm sorry, to about the 5th thoracic vertebra. The walls of the trachea will be lined with ciliated epithelial tissue. And if you think about the role of the cilia, there are parts within the respiratory system that have cilia that are non-motile, okay, and that's in the nasal cavity actually, that are responsible. They're in the olfactory area, responsible for just the sense of smell. Now, as we move through the conducting system of the respiratory tract, we learn that the ciliated cells within these areas are responsible for moving mucus. Now, most of the conducting division will have goblet cells within it, which, remember, a goblet cell is a unicellular gland that produces mucus. The purpose of mucus is for, yes, lubrication, less friction, stuff like that, but primarily to trap dirt and particles or whatever gets in there. And then your body can do a first line response immune system wise. Now the cilia then come into play when we want to move the mucus up and out. The trachea, okay, along with the epithelial tissue, it is primarily comprised of C-shaped rings of hyaline cartilage, okay, and they're C-shaped because the most posterior aspect of these rings, there's an opening. The ends of these C-shaped rings will be connected by the trachealis muscle. This muscle will allow the trachea to be flexible and expand, okay? Remember, the esophagus is posterior to the trachea. So if you swallow something a little bit larger, this opening in the back end of the trachea then will allow, like if you're swallowing something big, not to like crush your trachea, right? Have some flexibility and motion in there. From the trachea, or what branches off then, are what we call primary or main bronchus. You'll have a left and a right, one going to each lung. Off of the main bronchus, you're going to have a secondary bronchi or a lobar bronchus, okay? Secondary comes again off of the main bronchus, or if we call them the lobar bronchus, we can understand that they go to lobes of the lungs respectively. Each lung will have lobes. The left lung only has 2 lobes divided by what's called an oblique fissure. Another identifying mark of the left lung is that it has a cardiac impression. The shape of the left lung also is a little bit wider and shorter in contrast to the right lung. The right lung is more narrow and longer and has 3 lobes. The 3 lobes will be superior, intermediate, and inferior lobe. 2 fissures that will divide the lobes, the horizontal fissure and an oblique fissure at the most posterior or inferior aspect. Now, these bronchi, again, secondary bronchi will go to each lobe. So the right lung having 3 lobes will have 3 secondary bronchi, and the left lung having 2 lobes will have 2 secondary bronchi. Off of them, the secondary bronchi will have tertiary bronchi. You're going to have 8 on the left and 10 on the right. They just divide into more. They just keep dividing down into smaller places. Off of the tertiary bronchi, we have what's called a bronchiole. Okay, and at the ends of the bronchiole, we will have the growth of what's called the alveoli. The alveoli are the place where the respiratory division of the respiratory system begins, meaning this is where gaseous exchange takes place. The walls of the bronchial branches, but not the walls of the bronchioles, are reinforced by cartilaginous rings. The increasingly smaller branches of the bronchi are often compared to the branches of a tree. So this whole system here of the conduction system is called the bronchial tree. Okay, so trachea, I already mentioned, lined with ciliated epithelial tissue reinforced by the C-shaped rings. Here's a great picture so that you can understand this. This is also on page 316 in your book. The posterior aspect of these rings connects the back ends of the C-shape and creates the trachealis muscle. Okay, so your bronchi, again, primary bronchi, come off of the trachea, supply left or right lungs. This is really interesting. Okay, these main bronchi that come off the trachea, they're a little different in construct. The right bronchi is going to be wider and at a steeper slope coming off the trachea than and it's a little bit longer. Okay, the left main bronchus is going to be at a more horizontal angle, so less of a steep slope, and it'll be more narrow. So if you aspirate something, the likelihood of it going to the right lung is a lot higher. Okay, the alveoli, again, this is where our respiratory division actually begins. The alveoli are air-filled sacs or grape-like clusters. They look like little balloons. There are millions of clusters of alveoli that make up the bulk of the lung tissue. The alveolar walls are composed of very thin squamous epithelial cells. That should make sense, right? If we have, and we learned that in the tissue division when we were on that chapter, I believe that's chapter 4. You have this simple squamous epithelial lining. By design, the gaseous exchange has to happen really fast. So here we're going to see that that's possible. Now the interior of the alveoli are coated with surfactant. So the surfactant serves multiple purposes. Okay, primarily it helps the pressure within the lungs. It helps hold the alveoli open. So it helps prevent the lung from collapsing with pressure changes. Gases and macrophages travel between alveoli via pores of Kohn. These are small openings within the alveolar wall. Okay, the lungs themselves, I already went through the lobes. Similar to the heart, the lungs are conical in shape, meaning they have a base and an apex. The lungs will sit within the pleural cavity, within the thoracic cavity, which is the anterior, one of your anterior body cavities. The mediastinum sits between them. So the pleural sac, this is the double-walled sac that is comprised of 2 serous membranes. We have the parietal pleura, which is the part of the pleural lining that comes in contact with the wall of the body. And then you have the visceral portion, which will touch the actual organ. Both layers will secrete serous fluid. This will help reduce friction. As we get into then the actual physiology, the things that we'll notice that are actually taking place within the definition of respiration will be pulmonary ventilation, external respiration, respiratory gas transport, and internal respiration. So within pulmonary ventilation, this is breathing. Pulmonary ventilation is the breath. It's the cycle of the breath. External respiration refers to bringing oxygen from outside to inside the body, whereas internal respiration refers to what happens at that alveolar level. Respiratory gas transport refers to, I think the words, really are very clear here. It explains to us that through these processes of internal and external respiration, that there is oxygen transported to body, cells and tissues, and carbon dioxide transported away and exhaled. So within respiration, we have to understand a little bit about pressure, atmospheric pressure, air pressures, stuff like that, to understand that's how it truly impacts the body. So there's something called Boyle's law. Boyle's law states that the volume of a gas is inversely proportional to its pressure. So more simply put, the volume of a gas will increase as the pressure of the gas decreases. So let me say that again. The volume of a gas increases as the pressure of the gas decreases. So why this is relevant is because it affects breathing because of the differences between air pressure and intrapulmonary pressure. So the air that's pushing down on us in contrast to what's inside of our lungs. At rest, both atmospheric and intrapulmonary air pressure are 760 millimeters of mercury. When these pressures are the same, lung volume or amount of the air in the lungs does not change. At this point, there's no airflow. For the lungs to be able to take in air, the intrapulmonary pressure must be less than the atmospheric pressure. When the direction of airflow is reversed to expel air from the lungs, the intrapulmonary pressure must be greater than that of the atmospheric pressure. I mentioned that within pulmonary ventilation, it's the cycle. Okay, so it includes inspiration as well as expiration. Under normal circumstances, blood becomes 98% oxygenated in 0.75 seconds. The factors that allow gas exchange to occur so quickly include surface area, the diffusion constant, and the partial pressure of oxygen and carbon dioxide, and the thickness of the tissue. The relationships among these factors are explained by Fick's law of diffusion. Fick's law states that the diffusion of oxygen and carbon dioxide between the capillaries and the alveolar sacs is proportional to the surface area of the lungs. The diffusion constant D of each gas and the difference in partial pressure between the capillary and the alveolar sac, which is P1 minus P2. According to this law, the diffusion of the gases is also inversely related to the thickness of the tissue involved. In simpler terms, thin-walled tissue allows for easier gas exchange. I don't think that's a hard concept to grasp, but we make it complicated, don't we? Okay. The surface area of a lung is very important, okay? Which is also part of the reason we have, or we can extrapolate to understand the presence of alveoli. They're round, providing more surface area, and there's a bunch of them. The diffusion constant of a gas is proportional to its solubility, but inversely related to the square root of its molecular weight. Okay, so let's break that down a little bit so you understand that a particular gas will have a different rate of diffusion. Oxygen, having a lower molecular weight than carbon dioxide, should diffuse more quickly. However, the solubility of carbon dioxide is 24 times greater than that of oxygen. When we talk about partial pressure of gases, we have to understand that's a big deal. Again, that's atmospheric pressure down on us. So the partial pressure of a gas due to potentially elevation. Okay, if you're at sea level, there's a different partial pressure of oxygen than there is on top of the Rocky Mountains, which will then account for, elevation sickness, etc. Okay, so when we're talking gas transport, this is again taking blood from that internal part in the alveolar sac, crossing it across membranes, which is really relevant, into the bloodstream, and then being able to link up with red blood cells. Each gas is transported by binding to specific molecules. Oxygen is primarily transported by hemoglobin, and carbon dioxide is primarily transported by the bicarbonate ion. Although hemoglobin can take up some carbon dioxide, and keep in mind, carbon monoxide will compete for oxygen's presence there. So once in the bloodstream, 98% of oxygen is transported by the hemoglobin and picked up by the hemoglobin for transport to peripheral tissues. As the oxyhemoglobin molecule is transported throughout the body and plasma, oxygen is dispensed to cells in the peripheral tissues that need oxygen to survive. Exercise, which causes an increase in the body's pH and temperature, results in a greater unloading of oxygen by hemoglobin. These factors help to meet the increased oxygen demands that occur during exercise. Carbon dioxide is transported in a few different ways. In peripheral tissues, carbon dioxide will bind to bicarbonate, bind to hemoglobin, or dissolve in plasma. Approximately 60% of carbon dioxide is bound to bicarbonate. So some ways we need to get air to move. Again, when we want to do a whole breath, a whole cycle of breathing, we're talking inspiration and expiration. So external respiration comes into the body, then we go through an internal respiration process, which is the actual gaseous exchange, and then we have an expiration on the back end of that. But besides just the cycle of breathing, we can change the way pressure is in the lungs. We can cough, sneeze, hiccup, or yawn. Now, in regards to controlling respiration, we have to look at gender, age, and our position. Women generally have higher respiratory rates than men, and women will generally have a lower lung capacity. Respiratory rate may be influenced by physical factors, again, such as postural position. This could be going from sitting to standing, etc. So these things are changing all the time. Some of the neural factors that are in charge of respiration, this would be changes or stimulus to the medulla at an external and external intercostal muscles, so muscles in your rib cage. You have stretch receptors that will trigger what's called the Herring-Brewer reflex. This will help prevent overinflation of the alveolar sacs. And once it's activated, stretch receptors will send nerve impulses back up to the medulla via the vagus nerve and alert the medulla to stop the inspiration and then to begin exhalation. The pons comes into play where it works to achieve smooth transitions between in-breath and out-breath. Now we also have chemoreceptors. Okay, chemoreceptors are special sensory cells that are going to respond to the stimuli. Okay, we do have these located within the nervous system, located within the medulla. They're going to monitor changes in pH and thereby levels of CO2 within, in this case, within the CSF. If it's peripheral, we're going to have chemoreceptors located within your aortic arch and in your carotid arteries. This is also going to monitor carbon dioxide and pH changes, but it's going to remain in the blood. Now, another factor that's going to contribute to the regulation of your breath will be mechanoreceptors. These are instilled or inspired in order to regulate respiration. They are located within muscles and joints, and they're there to detect muscle contraction and the force generated during exercise. Lung volume. Okay, when we get into lung volumes, this is where we get into understanding some of the language. So lung volumes, starts on page 327 in your textbook, and we're going to walk through some of these concepts. Lung volume will vary according to age, height, weight, gender, and race. Therefore, it's important to use an appropriate set of normative values to understand where a person should be. And this will help us diagnose and then appropriately treat someone with a lung condition and to do some further sleuthing. So static lung volume, this is where we measure this volume to be able to determine whether there is a deficiency or disorder. Static lung volume is measured using a spirometer. The person will perform a series of breathing maneuvers. First, the person is instructed to breathe normally into a spirometer for at least 6 breaths so that a measurement of what's called tidal volume can be obtained. The tidal volume is the amount of air inhaled during a normal breath. Then the person inspires maximally, breathes in as deeply as possible, followed by a maximal expiration into the spirometer again. So we have this normal breath, relaxed, straight, just normal breathing in and out. That's tidal volume. Then when we have a forced inspiration of force or maximal, okay, inspiration and expiration, this will help identify what's called vital capacity. This is the total amount of air that can be forced during inspiration. There is a volume of air that's never going to leave the lungs. This is called residual volume. The residual volume is important because it allows gas exchange to occur continuously between inspiration and expiration. The residual volume cannot be measured by a spirometer, and it's a calculation that we're doing. So some other measures that we want to look at, there's something called IRV, or inspiratory reserve volume. This is the amount of air that can be inhaled immediately after normal inspiration. There's an ERV, expiratory reserve volume. This is the amount of air that can be exhaled immediately after normal expiration. Then we have something called FRC, or functional residual capacity, the amount of air that remains in the lungs after normal expiration. So we have ERV, expiratory reserve volume, plus RV, residual volume. Then we have TLC, or total lung capacity. This is the total amount of air that the lungs can accommodate. This is a combination of vital capacity and residual volume. So of all the measurements, we can obtain them from using the spirometer, except for the FRC, which requires the calculation. Okay, so here's our spirometer testing. As we can see, we have all of our values and volumes labeled on here. This picture is on page 328 in your book, and I encourage you to look it over so you have an understanding of what everything means. When we're talking dynamic lung volume, this is a measurement of flow rate during a forced vital capacity maneuver. So pulmonary function testing is performed using a computerized flow volumeter or peak flow volumeter to measure dynamic lung volume. The pulmonary function test is very important because it can determine whether a person has obstructive lung disease or restrictive lung disease. The goal for a person getting these dynamic tests done is to breathe out for at least 6 seconds. This may not sound very hard, but most people cannot expire for 6 seconds on their first attempt. The most important measurement obtained from a dynamic testing procedure will include what's called forced expiratory volume in 1 second, or FEV1. This is the maximum amount of air that a person can expire in 1 second. This measures our lungs' ability to push air out. Then we want to look at forced expiratory volume in 1 second, or what's called over forced vital capacity. This is the proportion of vital capacity that an individual can exhale in the first second of a forced exhalation, and measures the overall expiratory power of the lungs. So the point here, why we want to do this, is we're looking for obstructions or disease. So people with COPD, or asthma, chronic bronchitis, anything that's gonna obstruct an airway, we're gonna have trouble exhaling. As a result, the FEV and FEV over FVC values will be less than 80%. People with restrictive lung diseases, such as cystic fibrosis or pneumonia, will have an increased stiffness in the lungs, which will prevent them from expanding normally. So this lung stiffness can cause static and dynamic lung volume changes. So again, we're looking at all these measurements on volumes as a way to determine if we have restriction or disease. Okay, so in the developing embryo, some things we want to notice or talk about. Oxygen and nutrients are received from the blood via the umbilical vein. Okay, I don't think that's probably hard to extrapolate. The carbon dioxide and waste products are removed through blood in the umbilical arteries. So maybe that is a flip on what we're used to seeing. Okay. The amniotic fluid, as we're aware, will protect the baby. It aids in temperature regulation, cushioning, a nice amniotic nutrient bath. Now, following birth, we have the better development of lungs. And I think we know this as well. There's a chart on page 331 I'm going to walk through for lung development in utero. So, and in the embryonic development phase between weeks 3 and 6, we see small buds branch off from right and left lungs. We see larynx and trachea formed. We see the buds of the 2 main bronchi develop. These will eventually develop from bronchi and all other lower respiratory structures. Then within embryonic development, we see something that we call pseudoglandular. This happens between weeks 6 through 17. And we see the lung buds branch further. We see all air passages formed and terminate into the primitive respiratory bronchioles. We see cilia and cartilage begin to form, and the amniotic fluid production will begin. In week 17 through 25, this is what we're calling the canalicular stage or phase, where we have bronchioles, alveolar ducts, and the foundations of the alveoli form. We also have surfactant production beginning here. In weeks 25 through 36, we have a stage called the saccular stage. This is where surfactant production will increase. This is a step that will allow amniotic fluid to drain from the lungs and allow the lungs to fill with air during delivery. Surfactant, what that is, it is composed of fatty molecules produced by cells in the alveoli that will reduce the attraction between water molecules within the alveoli. So it keeps them open, like we mentioned before. So right here in this phase, this is the concern with premature babies. Premature babies born at 28 weeks usually can breathe on their own, but it won't be strong necessarily, and that's when we have to have like incubators and such like that. Then at 36 weeks through birth and in early childhood, up to 2 years, we have more alveolar forming. So I hope we're seeing too that upon birth, we're still not fully formed, are we? It takes years and years to really get to max performance, I guess, or max capacity. So within infants and children, the alveoli will increase, and blood supply increases, lung capacity increases, and they should, due to this is why we have a danger with smoking around children or pollutants and bad air quality. Now in adults and older adults, as with everything, lung capacity starts to decline. Lung tissue will become less elastic, chest wall becomes stiffer, and we have fewer alveoli. So we have older people that are more susceptible to respiratory problems, which we know is illness, flu, pneumonia, lung diseases. That's not the only reason though, okay? There are multiple other reasons why we see changes in older adults. Okay, so when we're talking some of the diseases and disorders of the respiratory tract, we could have a pharyngitis. This is a common cold or flu, or strep A infection where we get a sore throat, fever, headache, swollen lymph nodes, where the treatment maybe to gargle with warm saline water, which is a magical little thing. We might need antibiotics. It depends on the origin. I hope you're aware that antibiotics are designed for bacteria, not for viral infections. Viral infections will usually whip through in about 7 to 10 days and do their thing. As we know, some viral infections hang on longer. A sinusitis, usually created by bacteria, viruses, or fungal infection. If you breathe in mold spores, you can have a response. Laryngitis, infections to the laryngeal region. Again, pathogenic allergy, something inhaled that's irritating. It doesn't have to be microbial. Okay, it could be a toxicant. Tonsillitis, viral or bacteria. I don't think any of us need coaching on COVID-19. We lived through that, right? If you, but you probably did, okay? It came out of pandemic and went into endemic. That's been discovered, okay? So it's here to stay. We're dealing with it like we've dealt, human physiologically with everything else. Influenza, it is a viral infection. You can have flu-like symptoms, okay? That's not the flu. You need tested for it. It says the best protection is the vaccine. I don't necessarily agree with that just because of statistics. I think that it can help in certain situations, but there are other things you can do to help as well. And the reason being is the statement prior to that, the strains differ from year to year. So it's a virus that mutates rapidly and they can't seem to catch it or keep up with it. Okay, upper respiratory infection transmission. This is, when we talk or breathe, when we respirate, okay, there are particles and droplets when we do that. So we're kind of spitting all the time onto everything. So transmission of respiratory viruses seems to be pretty easy to trade off. The cool thing is your body's amazing immunologically, generally, and hopefully. So natural immunity is a great tool. We just need to make sure it's our bodies can take the task. So, we want to cover our nose and mouth, wash our hands, avoid touching our eyes, nose, mouth, avoid touching or shaking people's hands. Also, I think one thing we did learn through the pandemic is if you don't feel well, please stay home. Okay. Even if you don't have a symptom, doesn't mean you're not transmitting. And what I mean by that is if you have a fever, shutting the fever down doesn't make you less contagious. It just means you don't have a fever. So, when we have to go to work or we have to do the thing but we don't feel well and we take the Tylenol so we feel better, it doesn't mean we're not sharing with everybody. Okay, so with acute bronchitis, when we have bronchitis, you can classify it as acute or chronic. Okay, usually when we have that, it's a time thing. So anything under 6 months of presentation, and this is back and forth, you can have a chronic situation that comes every year at the same time, but you don't have it all throughout the year. That could still be considered chronic. But an acute bronchitis is an inflammation of the mucous membrane, lines the trachea. And we'll talk about chronic bronchitis in a second. Acute bronchitis is characterized by a cough. It may or may not produce mucus. It can result from ongoing viral infections that you just can't get away from. And again, if we can help anything that will assist the body, okay, by expectorating mucus, enhancing the performance of the immune system, all of that stuff will be helpful. And when we get into pneumonia, this is varying origin. Can be virus, bacterium, fungus, parasite. Again, origin is different, and you would have to test to know what the origin is. Usually they're going to do a chest x-ray and they'll find fluid in the lungs. And then from there, they'll determine what kind of treatment that you need. When we talk tuberculosis, this is a highly contagious respiratory infection that will attack the lungs but can spread to other organs. And you can check that by breathing it in. If you develop COPD, this is a general category. This is any lung disorder characterized by long-term airway obstruction that makes it difficult to breathe. So again, chronic obstructive pulmonary disease. A third leading cause of death, major cause of long-term disability, and there's a frequency to upper respiratory infections. You can get dyspnea if it progresses and keeps going. So two forms of COPD that we are aware of are emphysema and chronic bronchitis. So in emphysema, usually this is caused by smoking, but you can just be, if you work in an environment where you're repeatedly exposed to particulate in the air, you can damage your lungs that way. The body will go into a hyperventilation, which will increase your respiratory rate. So it's hard to breathe. The characteristics will be pink cheeks and labored breathing. Now with chronic bronchitis, this is a cough that's lasted for 3 months to 2 years. People with chronic bronchitis have an obstructed airway due to inflammation from some origin and excessive mucus production. So we want to cough up the mucus. The face and lips of a person with chronic bronchitis will be blue because we're experiencing some type of hypoxemia. The residual volume in the lung also increases, causing a bloated appearance. These side effects have led to the description of chronic bronchitis patients being called blue bloaters. Okay, I don't think it's hard to understand the effects of smoking. Okay, we're aware of what tobacco does to lung tissue or any type of smoking. Now we're in an era right now where we've traded it off for vaping. Okay, I am not a vape supporter because there's stuff in there and there's not enough information on what it is. So personally, it's not a good trade if you ask me at all. Okay, so as with everything, we're saying there's no cure for COPD. Once again, I don't like that word. Okay, so often we think that like it stops and nothing else will go wrong. So often when we shut something off completely that's going wrong in the body, if we haven't done course correction, you're substituting one thing for another. Okay, when we talk about asthma, okay, this is bronchospasms within the airways. The lining of the lungs will produce mucus. We get this inflammatory response and constriction. Now, this can be from multifaceted things. It could be from food you eat. It could be from, cold air. It could be from inhaling particulate that you can't handle. And if you go into an asthma attack without a bronchodilator, we can go into a hypoxemic state. That's quite scary watching that happen. Lung cancer, I don't think this is surprising. There's two types, non-small cell or small cell, okay, and oat cell carcinoma. It does not have a good prognosis. If we get lung cancer, it metastasizes really quickly. One thing I don't agree with is saying that smoking is the main cause. I don't agree with that. Smoking contributes 100%. However, we know of other things that we come in contact with, or maybe we don't know, that could definitely contribute to lung cancer. A great example, one of my favorite examples, is radon gas. Okay, we've accepted that it's here, we can't smell it, we can't see it, but we're breathing it in, and it can be a contributing factor. So there are so many invisible variables here that I don't like saying smoking is the reason. So treatment options, as we know, radiation, chemo, and a lung resection. And I'm not sure, it says alternative options. Not sure that much is effective for that. Okay, and I believe that is all for this chapter. We'll see you in the next video.